You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
You're listening to the NASP Podcast. This specialty pharmacy podcast is a collaboration with the National Association of Specialty Pharmacy and the Pharmacy Podcast Network. The mission of the National Association of Specialty Pharmacy is to improve specialty pharmacy practice by promoting continuing professional education and certification of specialty pharmacists while advocating for public policies that ensure patient access to specialty medications. As the healthcare industry's leading podcast dedicated to the pharmacy profession, the Pharmacy Podcast Network is proud to bring our listeners the NASP Podcast, in collaboration with the National Association of Specialty Pharmacy.
Hello, my name is Sheila Arquette, and I'm the President and CEO of the National Association of Specialty Pharmacy. I'm delighted to welcome two very special guests, Dr. Andrew Lindsley, U.S. Medical Director at Amgen, and Dr. Davé, Director of Medical Value and Population Health, to this episode of the NASP Podcast. Andrew W. Lindsley, MD, PhD, is a medical director with Amgen and is the U.S. Medical Affairs Asset Lead for tezepelumab-ekko, or TEZSPIRE. Dr. Lindsley is a physician scientist and a board-certified pediatric allergy and immunology physician. Before joining the industry, Dr. Lindsley was an NIH-funded researcher based at Cincinnati Children's Hospital Medical Center. He has extensive clinical experience managing pediatric allergic diseases. His professional focus is to improve symptom control and quality of life for patients. As a pharmacist on the Amgen Medical Value and Population Health team, Davé, PharmD, MBA, collaborates closely with population health decision makers within the national and regional payer space, including specialty pharmacies. Before joining the industry, Ash accumulated over a decade of managed care experience at national managed care organizations and PBMs, collaborating directly with employer groups, employee health benefit consultants, specialty pharmacies, employer coalitions, and other key stakeholders in the healthcare ecosystem. Welcome, Andrew and Ash. It's a pleasure to have you here today to discuss TEZSPIRE and the management of severe uncontrolled asthma, or SUA.
Well, thank you so much, Sheila. We're thrilled to be here and to speak about TEZSPIRE, especially with specialty pharmacists who play such a vital role in the treatment journey of patients with severe asthma. Now, as you may already know, TEZSPIRE is approved as an add-on maintenance treatment for adults and pediatric patients aged 12 years and older with severe asthma. Importantly, it's not indicated for the relief of acute bronchospasm or status asthmaticus, and it may cause hypersensitivity reactions, including anaphylaxis.
Severe asthma is a significant burden on patients in the healthcare system. Can you share some insights into its prevalence and the challenges in managing it?
Hi, Sheila. Thanks again for having us. Sure. The prevalence of asthma in the U.S. general adult population is approximately 8%. Approximately 10% of adults and 5% of adolescents with asthma are estimated to have disease that is severe, of whom approximately half, so 45% of both adults and adolescents, are estimated to have severe uncontrolled asthma, i.e. they require additional therapy or change in therapy to bring the disease under control. Nearly 85% of U.S. patients with uncontrolled severe asthma are not receiving biologics. And even with receiving existing therapies, 60% of U.S. patients with severe asthma have exacerbations. Therefore, we can see that challenges remain in addressing severe uncontrolled asthma.
So those are some really staggering statistics. And it's apparent that the standard of care may not be enough for patients with severe uncontrolled asthma. Can you talk about the pathophysiology of severe asthma and the role that biologics, such as TEZSPIRE, may have in helping patients? And then how does TEZSPIRE fit into that picture?
Sure. Those are really great questions, Sheila. So severe asthma is a complex condition with multiple drivers of inflammation. We've learned that the epithelium of the airway plays a critical role in the pathophysiology of severe uncontrolled asthma, where multiple triggers ranging from allergens to pollutants to viruses to bacteria and to other environmental insults can all lead to the release of thymic stromal lymphopoietin, or TSLP. Now, TSLP, which is known as an alarmin, is a key epithelial cytokine in allergic disease and asthma, and it modulates multiple downstream pathways that can drive airway inflammation and contribute to airway hyperresponsiveness, which is also a way of saying the twitchiness of the airway. The airway concentration of TSLP has been shown to be prominently elevated in patients with asthma and is associated with asthma severity, risk of exacerbations, and reduced lung function. Now, another point is that on average, patients with severe asthma have 8 different triggers for their asthma symptoms, which can result in release of TSLP and activate multiple inflammatory drivers. Additionally, many patients may have overlapping, mixed, or changing phenotypes. For example, we know from the National Health and Nutrition Examination Survey, or the NHANES survey data, that nearly half of patients with asthma have a mixed allergic and eosinophilic form of asthma, which was defined as having an allergen-specific IgE level of 0.35 international units per milliliter or more, and a blood eosinophil count of 150 cells per microliter or more.
So you mentioned how people's phenotype can change. So do they go from having an IgE-mediated asthmatic presentation or eosinophilic and then just something else? Or what did you mean by that?
Sure. Well, there are lots of different patient journeys, and as you know, many different paths to asthma and severe asthma in patients. There are some patients that start off early in life and have allergic disease, especially young children and adolescents, who can sometimes be more allergic. Then over time, they can also have those allergic sensitizations become a more prominent part of their asthma. Whereas with adult onset asthma, it's less likely to be driven by an allergic disease, and it can be more of a pure eosinophilic phenotype. So depending on the age of onset of the disease and the age of the patient, the phenotypes can be fairly distinct. Then you have plenty of people who are what we call T2 high, where they're both allergic and have high eosinophil levels. And then just to make it even more complicated, you can have the inverse of that, where you have people who are T2 low and they have neither elevated blood eosinophil counts or specific IgEs to allergens.
What mediates that blood eosinophil count, that rise for some patients? What causes that?
Well, blood eosinophil counts are closely linked to a survival cytokine called IL-5. And IL-5 secretions comes from a variety of cells in the lungs and in circulation. Most prominently, it's secreted by Th2 T cells, which produce IL-5, and also innate lymphoid type 2 cells. They both produce IL-5, and they enhance the survival of that type of granulocyte. And then those eosinophils, when they accumulate in the lung, they're associated with asthma exacerbations. So how is this all connected to TSLP? Well, TSLP is at the top of the inflammatory cascade and can impact the release of downstream mediators. Thus, TSLP is very important for severe uncontrolled asthma. TEZSPIRE is a first-in-class human monoclonal antibody that is known to block TSLP's ability to interact with its receptor, and it works at the top of the inflammatory cascade, reducing the release of downstream mediators. It's important to note that the mechanism of action in asthma has not been definitively established. So TEZSPIRE is indicated for the add-on maintenance treatment of adult and pediatric patients aged 12 years and older with severe asthma. It's not indicated for the relief of acute bronchospasm or status asthmaticus, and use of TEZSPIRE is contraindicated in patients with a known hypersensitivity to tezepelumab-ekko or its excipients. Now, the most common adverse reactions, those that occur in greater than or equal to 3% of the study group that were associated with the use of TEZSPIRE, are pharyngitis, arthralgia, and back pain. And also, I'd like to remind listeners to stay tuned until the end of this program so they can hear the full set of important safety information for TEZSPIRE.
All right. So can we now talk about the clinical data? Can you walk us through the key results from the pivotal trials of TEZSPIRE?
Sure, Sheila. The efficacy of TEZSPIRE was evaluated in 2 clinical trials, Pathway and Navigator. Both trials were randomized, double-blind, parallel group, multi-center, placebo-controlled clinical trials of 52 weeks in duration. Pathway was a phase 2b trial conducted in 550 adult patients aged 18 to 75 years having severe uncontrolled asthma. Navigator was a phase 3 trial conducted in 1,061 adolescents or adults aged 12 to 80 years having severe uncontrolled asthma. Both trials had similar designs and inclusion criteria. Patients were required to have a history of 2 or more asthma exacerbations requiring oral or injectable corticosteroid treatment or asthma exacerbations resulting in hospitalization in the past 12 months, 1 in Pathway and 2 or more in Navigator. The primary endpoint was the rate of clinically significant asthma exacerbations measured over 52 weeks. We saw that treatment with TEZSPIRE 210 milligrams every 4 weeks resulted in a significant reduction in the annualized asthma exacerbation rate, or AAER, compared with placebo over 52 weeks. In Pathway, the reduction was 71%, and in Navigator, it was 56%. Additionally, reductions in exacerbations associated with hospitalization were observed with TEZSPIRE. 86% reduction versus placebo was observed in Pathway, and 85% reduction was observed in Navigator. Now that we've covered the pivotal trial data, perhaps we can talk about additional analysis across the key subgroups of patients with severe asthma. For example, we know that asthma is commonly driven by allergy and/or eosinophilic inflammation, both of which may be present in severe disease. Andrew, can you please talk about the data for TEZSPIRE in these subgroups?
Absolutely. Thanks, Ash. So it's important to note at the beginning of this part of the podcast that we're going to be talking about results that are descriptive only, and definitive conclusions cannot be made as they were based on pooled or post hoc data from the Pathway and/or Navigator trials. So now let's look at the TEZSPIRE data in patients who had eosinophilic asthma. In patients with eosinophilic asthma, reductions in the annualized asthma exacerbation rate were observed in patients with high baseline blood eosinophil counts. In patients with blood eosinophil counts of 300 cells per microliter or more, the observed reduction was 71% compared to placebo, whereas in patients with blood eosinophil counts of 450 per microliter or more, the observed reduction was 78%. Exacerbation reductions were also noted in patients with low blood eosinophil counts, including blood eosinophil counts of less than 150 cells per microliter, and that was 48% reduction compared with placebo. So next, in patients with allergy, who are defined as subjects who had a positive fluorescent enzyme immunoassay test, or FIA positive test, for any perennial aerol allergen, in that group of patients, we noted a 62% reduction versus placebo, compared to a 54% reduction in patients who did not have perennial allergy. FIA positive status was defined as at least one positive FIA test result or a serum-specific immunoglobulin IgE against one or more perennial aerol allergens, such as cat or dog dander, cockroach, dust mite, or mold. So in patients that had seasonal allergies, the observed annual asthma exacerbation rate versus placebo was reduced by 59% during the spring season, which was defined from March 1st to June 15th, and by 70% in the ragweed allergy season during the month of September. Lastly, in patients with blood eosinophil counts of 300 cells per microliter or more, and also having perennial allergy, defined as having a positive FIA test against a specific perennial allergen, in that group, we saw a 71% reduction in the annualized asthma exacerbation rate versus placebo. So now how about we shift gears a little bit? As specialty pharmacists, I'm sure our audience often deals with the logistics of medicine administration. Ash, can you tell us a little bit about how TEZSPIRE is administered?
Absolutely, Andrew. TEZSPIRE is available as an accessorized prefilled syringe and a prefilled pen for healthcare providers or HCP, patients, and for self-administration. It's a one fixed dose strength, once every 4 weeks regimen. There is no loading dose, no variation in dosing schedule, no adjustments based on weight or biomarker level. The functionality and performance of TEZSPIRE administration via an accessorized prefilled syringe and a prefilled pen in clinic and at home were assessed in a randomized open-label phase 3 study, Path Home. Over 91% of HCPs, patients, and caregivers were able to administer TEZSPIRE successfully both in the clinic and at home. And the proportions of successful administrations were comparable between devices and settings.
Administration, as the three of us know, is such an important factor. Now, you talked about TEZSPIRE efficacy in a broad population of severe asthmatic patients. Are there specific clinical criteria for using TEZSPIRE?
So as we discussed, TEZSPIRE demonstrated a reduction in exacerbations in a broad population of severe asthma patients and across asthma phenotypes. Because of that, some providers may think of TEZSPIRE as a last resort therapy. That's a common misconception. TEZSPIRE is indicated as an add-on maintenance treatment for adults and pediatric patients aged 12 years and older with severe asthma, period. The Global Initiative for Asthma, or GINA report, includes anti-TSLP therapy, meaning TEZSPIRE, as a recommended option for patients with T2 severe asthma with exacerbations or poor symptom control on high-dose inhaled corticosteroids and long-acting beta agonists. This is sometimes abbreviated as ICS-LABAs. In addition to these T2 severe asthma patients, GINA also recommended anti-TSLP therapy for patients with non-type 2 severe asthma. So, Ash, can we review some of the safety data for TEZSPIRE?
Certainly, Andrew. Before we close out, let's review the important safety information for TEZSPIRE. It's important to know that TEZSPIRE is contraindicated in patients with a known hypersensitivity to tezepelumab-ekko or its excipients. Reactions, for instance, rash and allergic conjunctivitis, can occur after administration of TEZSPIRE. These generally occur within hours of administration, but can have a delayed onset. So consider the benefits and risks for the individual patient. It's important to know that TEZSPIRE should not be used to treat acute asthma symptoms, acute exacerbations, acute bronchospasm, or status asthmaticus. Do not abruptly discontinue corticosteroids. Dose reductions, if appropriate, should be gradual and may be associated with withdrawal symptoms and/or may unmask previously controlled conditions. Treat patients with pre-existing helminth infections before starting TEZSPIRE. If patients become infected while receiving TEZSPIRE and do not respond to anti-helminth treatment, discontinue TEZSPIRE until the infection resolves. Avoid the use of live attenuated vaccines. Please see full prescribing information, including patient information and instructions for use, at tezspirehcp.com.
Well, this has been such a highly informative discussion. So to wrap things up, what are the key takeaways for specialty pharmacists when it comes to TEZSPIRE?
Sure. So I'd say the top points are that TEZSPIRE is a first-in-class biologic targeting TSLP, and that TEZSPIRE significantly reduced asthma exacerbations in a broad population of severe asthma patients, irrespective of key biomarkers. In addition, TEZSPIRE offers in-office or at-home administrative options with a pre-filled syringe or pre-filled pen. And on behalf of myself and Ash, I just want to say thank you to you and our listeners for tuning into this great exchange.
Well, thank you both so much, Andrew and Ash, for chatting with me and sharing this valuable information. As a reminder, NASP corporate members are invited to be my guest on one complimentary podcast per year. For more information about this or other NASP membership benefits and events, please feel free to reach out to membership@naspnet.org or visit our website at www.naspnet.org. Until next time, have a great day.